All right, everyone. Thank you for joining. My name is Amanda Bendor. I am the engagement lead for Pathways, and we're delighted to have you join us today for our first Pathways community webinar of 2026. Today's session is leveraging Pathways tools to inform forecasting, resourcing, evaluation, and design of RMN Plus programs. We have a fantastic lineup today. I think that you'll all really enjoy today's session as we hear from MSI Nigeria and their work using Pathways tools for service providers, and also hearing from Sonder as our colleague goes through a demonstration of the Pathways platform to inspire you how you all can use the data and the information on the platform to inform some of your own programs. So before we dive in, I'd like to ask you to introduce yourselves in the chat. Just say, your name, where you're joining from, and your organization. Those are great things to get the conversation going. I also have a very brief poll, so we'll see if we can get this to work. Um, just trying to get a little bit of information on where you all are joining us from. So hopefully that works for folks as they're starting to join us. I think what I'll do, maybe Pratasha, for the sake of time, we can go to the next slide and I'll just share a little bit about our agenda while the poll is going. Okay, so just briefly, this is our agenda for today. We will spend most of our time today hearing from two colleagues from MSI Nigeria on the fantastic work that they've been doing, and there'll be plenty of time for discussion. So as you're listening to their session, please put your notes in chat or come offline and share your questions during the Q&A so we can have some live conversation. As I said, Pratasha will share a demonstration of the platform, and we've even got a bit of homework or extracurricular activity for you all to take with you following the webinar to really practice what you're learning and dive into the segmentation data. And finally, I will wrap us up with just a few exciting updates for the Pathways community. Okay, I'm going to keep the poll open for a few more minutes. Pratasha, maybe we can go to the next slide so I can introduce our speakers. So we're pleased to welcome Ogechi Anahua, who's the Deputy Director from MSI Nigeria. She's a health and development professional with extensive experience leveraging evidence and learning to enhance client-centered demand generation and provider support across large-scale sexual and reproductive health programs. Ogechi's work encompasses donor engagement, program management, and health system strengthening, guided by a strong commitment to rights-based, women-centered healthcare. And joining her will be Chibike Utaka. Chibike is a health communication professional with years of experience delivering multi-platform health information and communication for demand generation. He leads the demand generation and social and behavior change communication activities at MSI Nigeria, leveraging relevant community level and modern approaches to increase uptake of sexual and reproductive health products and services. And finally, we'll hear from Pratasha Roth. Pratasha is an applied behavioral science and human-centered design specialist with extensive experience leading projects aimed at solving complex business and social problems with a focus on sustainable behavior change. She has led multiple mixed method studies with cross-functional teams across India, Eastern, and Western Africa. So thank you so much all for joining. I think we can go to the next slide, Pratasha. And our colleagues at MSI can kick it off. So over to you.
Thank you, Amanda. I will start and then I'll also call on my colleague to also carry on. I will start with an introduction about MSI. So MSI Nigeria Reproductive Choices. We are a women-focused organization. We lead family planning provision in Nigeria, covering comprehensive sexual and reproductive health. And our work in Nigeria is focused on empowering women, their household, and their communities to ensure that they have the right information and they can make informed choice.
6,000 pounds.
They can make informed decisions as regards their reproductive health, and that they are enabled to access services on their own terms. The communities are enabled to support them, their partners are enabled to support them, and the women can actually have this access to reproductive health services. We work in the whole of Nigeria, 36 states, and the Federal Capital Territory, working collaboratively with the government at the federal and at the state level. Our work is also very strong at the government level. Nigeria currently has 788 local government areas, and our work currently, at the end of 2025, we were supporting intervention in 80% of these 788 local government areas. One thing we have learned in the course of our work is that one size does not fit all, and that has enabled us to come up with multiple channels of service delivery, some of which are focused in attending to clients in the communities. So across board, just to take you through our service delivery channels, we have the outreach channel. The outreach works in the very last mile locations, crossing mountains, crossing rivers, to ensure that those women who would not ordinarily have access to services are able to get the services. We currently have 34 of these outreach teams who are working across multiple states to reach women in the most difficult terrains in Nigeria. We also have what we call our Maristopes ladies. These are nurse midwives who are resident in communities and are providing services. We are particular about this channel of service delivery because they help us reach women who are in restrictive environments, particularly those women who are in PUDA, and also women who are living in security compromised locations. And the reason they're able to reach these women is because they reside in those communities. So even when the regular health system is not able to attend to them and meet their reproductive health needs, these Maristopes ladies reside in those communities and can reach them. As at the end of 2025, MSI Nigeria was supporting about 17% of the public health facilities in Nigeria, and that puts it at over 5,000 public health facilities across the states in Nigeria. We also have what we call our Maristopes centers. These are owned by MSI Nigeria, and we have 6 of them currently in Nigeria. We have a contact center. The contact center work is primarily very important because they support continuum of care. Regardless of where the woman is, where the caller is, or who the individual is, they can call 7 days a week into the contact center and get somebody, pick up the phone and respond to their needs, link them up to a service delivery point if their need is to take up service, provide counseling and guidance over the phone if their need is to seek such guidance, and as well give us feedback in terms of what we can do best in terms of improving our care and our service across communities. So this contact center is toll-free. Whether the woman has credit or not, they are able to call and they get the support they need to access care. We also have our social marketing that do distribution of commodities and products across the states. These are quality assured reproductive health commodities, ensuring that Nigerians have access to quality assured commodities. And we are really excited to say that in 2025, we were able to reach over 4 million clients in Nigeria with reproductive health services. Next slide. Now, bringing it home to the conversation we are having this afternoon. What was the challenge we had, and why did we think it important to engage with the pathways data and use that to generate insights? From what we know, women are faced with multiple vulnerabilities, and that impacts on their ability to access care when they need those care. What the pathways data did is to use evidence to segment the women into different segments based on their vulnerabilities. And when we were exposed to this data, we found it very interesting and insightful. And the question ringing in our mind as an organization and as a team is, how can we leverage the insights coming from the vulnerability segmentation of the pathways data to improve the work we are currently doing? MSI is very much interested in ensuring that every woman and every household has access to the information to plan their family size and have that family size that they desire. But we also know that it's not one size fits all. What will appeal to different segments will differ. So what we did was, how can we leverage this data to improve our work? And how can we convert these insights into bite-sized tools that can enable our providers and our teams to work more efficiently and deliver greater results? And that was the mindset where we are at when we saw this, and we began to engage with Pathways to have conversation. And Pathways data actually looked at activities and the statistics in the states where we are operating in Nigeria as a whole, but particularly in Kano and in Kaduna states. MSI currently, we have 26 community-based social behavior change commission officers working in these two states. We are currently working with over 800 community-based mobilizers who work in communities to engage community stakeholders and mobilize clients into facilities where they can obtain services. And currently, we are also having over 900 service providers working in these two states to provide reproductive health services to the women. And these are made up of nurses, midwives, and CHUs. Now, our approach that we deploy in terms of community mobilization is we use community dialogues. We also have compound meetings which happen in households, and we have one-on-one conversation with these clients before they are moved into the service provision points for service. But one thing that was very critical for us, and this is where we engage Pathways, was how do we ensure that the conversations happening in the counseling room are better targeted? The provider who is having a time challenge can better target her conversation to the vulnerability of the woman that is sitting in front of her and best meet her need. How can the mobilizer who is working in the community be able to make quick decisions based on the profile of the individual that he or she is engaging with, and then target her intervention to suit the needs of that woman by addressing those barriers that are limiting her from accessing service? How can we engage the men who are influencers to these women and be able to enable the right environment? So this was what led us to co-create with Pathways. We had a co-creation workshop where we brought together MSI team, the Pathways team, the stakeholders from the government in the two states of intervention, as well as community-based mobilizers and service providers, looking at what will work best and how do we deploy this more efficiently. And that was what led us to the documents and the tools that were co-created. Beyond the co-creation activity, there were multiple engagements at the state level, engaging with government and partners to further have that collaboration that is required for a successful rollout of the activities. Just to reiterate again, we are looking at the challenges how do we ensure that messages are better targeted to the needs, vulnerabilities, and barriers that are limiting service uptake by the women that we are targeting to serve? And how can our teams ensure that we deliver counseling to these women, addressing their needs and saving time, which our providers do not have? And I'm excited to share that we were able to come up with two tools, one serving the service provider and one serving the community-based mobilizer in mobilization. And I'm going to pass on right now to my colleague, Chibike Utaka, to walk us through the tools and how we deploy them. Over to you, Chibike.
Thank you very much. Good evening once more, depending on where you are joining us from. So thank you, Ogechi, for that bit of presentation. So in creating those tools, just like Ogechi mentioned, there's no better way to do that other than to also engage and involve those people who are going to be using those tools. So part of our team that designed the tool involved the community-based mobilizers, the social and behavioral change communication officers, as well as representatives from the Health Promotion Office of the State Ministries of Health for Kaduna and Kano. So we created two tools. And the idea is basically to address some of the challenges that Ogechi had mentioned: time, suitability, and being able to, have proper targeting of messaging. So we created a listening tool, and then we created a typing tool. And listening tool is basically a small booklet like this that had like small questions, set of questions in them that will help easily identify the profile of the person you are talking to. And this particular typing tool was basically useful for the mobilizers in the community, and he had inside it he had cues that will take you to the kind of person that you are talking with when you meet the person in the field. And that was basically what helped the mobilizers, to tailor their messaging depending on who they've met, whether in the rural or the urban communities. Using the typing tool, it was easier to go straight into the profile of the person and know the kind of messaging and the kind of things that would basically be able to be relatable to the person. We also created a listening aid, specifically for service providers during their one-on-one counseling. How would they be able to profile the woman sitting down before them and be able to know what are the kind of messages that will resonate with this woman? What are the kind of things I need to tell this woman? How can I be able to counsel this woman better to be able, on her journey to take up family planning? So it was basically a tool designed to reduce that time in terms of counseling a woman and being able to identify where the woman sits within the pathways profiling. Next slide. So these are the tools that I mentioned, and you can see our SBCC officer in the field using the typing tool. You can also see in the middle there our service provider using the listening aid, and this is what the inner part of the typing tool looks like by the side there. So basically, it's a small booklet, easy to carry, for the people in the field to use. Next slide. All right, so yes, so this is what the listening aid looks like. So to curb time, the listening aid basically is like a one page like this that had everything in one. So as the provider is looking at it, it's easy for the provider to tell that, oh, this woman sitting here is falls within the profile of aware reactive or falls within the profile of worried potential. And the beauty of this listening aid is that it basically had like cues that could tell the service provider what to do next, what to say next, what not to say, and how to guide this woman through having understood the profile and having understood where the circumstance of this woman is in life. So you can see in the middle of these two where you have the don'ts, the kind of things that you shouldn't say at that point, the do's, what you should say to this woman at this point, the health, basically what you tell the woman, planning, what next step, method, the kind of methods that you would reassure this woman is available, the kind of support this woman needs, the kind of follow-up that this woman needs, and all that. So basically, it was a good prompt in one page that encapsulated every single thing that would help a provider do a proper counseling in a shorter time, and being able to speak specifically to the particular woman with her or with him. Next slide. All right, so this is also because the listening aid, just like the typing tool also, we have for rural and we have for urban, segmentation. So basically, whichever one the mobilizer or the service provider finds, categorizes the person with, where they will flip through to be able to administer. And it's also the same thing. So basically, it has the snapshot of the pathways as segments and profiles. So next slide. All right, so with all these, after the development of these tools, we thought that, okay, the best way to figure out if we have been able to achieve the aims of this tool in terms of answering the questions and responding to the challenges for community mobilizers and for service providers is actually to deploy the tool in the field and have a little pilot of a smaller size use in the field. And this was done basically with some social and behavioral change communication officers and community-based mobilizers in Kaduna and Kano, as well as also identified service providers. And what we wanted to find out for the providers, basically to test the usability of the tools during counseling, to find out if actually the tool meets the expectation, if actually is something relevant to them, and how much it helps with the existing tools that they have, as job aids. And for the mobilizers, we're basically testing how it helped them to target, in terms of their message targeting, to speak directly to the people that they have found in the communities. And also, because our approach is also to ensure that we are also carrying everybody within the system along. It has a very huge component of the government representatives being part of the design of this tool. And as well, during this testing, we also went back to the government to also give them this tool to see how relevant they find the tools in terms of the existing policies, the strategies they have for family planning in the states, and also figure out whether this tool is something that they are willing or is scalable within the states in terms of family planning interventions. Next slide. So here we are going to be looking at what we found in the field. So after a couple of weeks of using this tool in the pilot stage in the field, our team went back to the field to ask questions and to be able to meet the users, the community-based mobilizers, the service providers, and these are what we are learning. So for the typing tool, we found that it was very effective during one-on-one conversations in both rural and urban settings where these tools were used. It helped the demand generation team to be able to identify behavioral profiles of the people that they are meeting in the communities and be able to focus their conversations to address the particular profile based on the pathways data available to them. And as you can see, one of the community-based mobilizers in Kaduna State said that it's quite effective during one-on-one mobilization, especially with adolescents also. So beyond even the larger profiling, also they found this to also be, to resonate with adolescents in their mobilization as well. The typing tool was seen as being simple and easy to use, because this is also part of the biggest concerns that we have. If they will find this very easy and if it's going to be adaptable to the existing tools that they have. And we could see from one of the SBCC officers saying that engaging the tool helps us a lot during individual mobilization and makes it easier for community mobilizers to do their jobs. These tools are coming to strengthen. Okay, so from the government bit also, we found that the MIE officer from Kaduna State mentioned that the tool aligns with what they have existing within the system. So it's not going to be a difficult, or it's not going to be an entirely new or alien tool for them to begin to adapt. So it's adaptable within the tools that they have, and then what they want to also do in terms of mobilization. And just to mention also that we are also in these states, we are also working in Kano State, for instance, as well as Kaduna State, to help in terms of designing an SBCC strategy for the states. And this is in process now. So from the feedback we got from them, this kind of aligns with those plans in place for demand generation in the state. However, we also found that this tool was seen as most useful for demand generation when we are having one-on-one conversation than when we have group conversations. Um, like Ogechi mentioned in the beginning, some of our demand generation activities happen in group community dialogues kind of setting and all that. So, but they found that the tool speaks closely to when one-on-one, it's easier to use than it is for group conversations. We also found that in terms of demand generation, also translation in Hausa is something that they found challenging because it's currently in English, it was designed in English, but they found that it's be better to also have the tools in Hausa because their mobilization is actually done in Hausa, depending on the kind of community where they are speaking to. So they felt that an Hausa translation would be very suitable for this tool. Next slide. So for service providers, listening aid was also tested and also across stakeholders for content relevance and for ease of use. Just like I mentioned earlier, we found that this aligns with stakeholders' priorities. So the Ministry of Health stakeholders found that this is also a good tool which serves the purpose for their approaches in the family planning and reproductive health work that they do. They found this tool to be very user friendly. As you can see, they are not bulky and they are very self-explanatory. It had gone through various processes of in development, so it's very easy to use, very clear, and they found it very effective in structuring their conversations when they are having counseling sessions. Now, we also wanted to find out how this tool integrated with the existing tool, like I mentioned. So in as much as we have job aids that service providers use, they felt that this also is not basically like an additional burden for them. So it doesn't create an additional layer of work for them to do. So it aligns also with the existing tool that they have. And it was easy for them to use it and speak on to it and also use it to achieve the same purpose they would have achieved using the other existing job aids that they have. So they also found that it was relevant, in determining clients' profiles. They found that it was relatable in the field to the kind of clients that they are seeing every day. So these tools also speak to those clients, meaning that it is relevant and is relatable to the work that they are also doing. We also found the same translation challenge where if they found that if the English version, if they are administering it on in Hausa language, there's this kind of overlap. So the recommendation here is basically to have an Hausa version created for these two as well. Next slide. So having gone through these findings and all that, so we are also internally looking at the next steps, and part of our next steps in the short term is basically to adapt the tools which we are doing, adapt the learnings that we have found from the field testing, and finalize it and do translations so that they can now be cascaded and deployed across all the facilities that we are working in Kaduna and Kaduna. We're also in the process of planning a cascade training, the cascade training for mobilizers and cascade training for service providers on how to use the tools more. Is something that we are also planning, and that's in the pipeline, should happen in a couple of weeks to come. However, in the long term, we are also looking at scaling up these two across other operational facilities, beyond the 2 states where we have tested this tool. We also plan to create, because of how relevant the messages and some of the data that we found from the pathways, how relevant they are, We are also thinking that they are very useful to some of our leave behind messages and materials that we keep. For instance, you visit a service provider after counseling, they could give you a small leaflet, a small flyer to go with. We are planning to adapt some of the pathways data messages into that kind of material to be able to also help in our service provision as well as our community mobilization activities. We found some of those insights very useful for the messages that we want to create as part of our demand generation, promotional and IEC materials to use in the long run. So that's basically our learning so far and our findings so far from this developing these tools, and they are very, very useful and very relevant to the work that we do in terms of helping and supporting the woman out there on her journey to take off family planning. Thank you.
Wonderful. Thank you so much, Shibike and Ogechi. What a fantastic presentation and what insightful learnings. We've got a little bit of time for Q&A. So I encourage you to put your question in chat or raise your hand if you want to come off mute. It's a little bit more engaging to ask your question. And I see we do already have a question in the chat from Andrew. Andrew, can I convince you to come off mute and ask your question?
Sure. Thank you so much. I was just trying to maybe go a little bit deeper on that next step slide. It was fantastic to hear about the current short term as well as the long term intentions and next steps. But are there, further plans to design new outreach interventions or augment them going forward? Is that iterative experimentation and design development still part of what's planned for the future? Over.
Thanks, Amanda. Should we take questions? Should we respond after each question or have it collated?
I think you can go ahead and respond to that question.
All right. Thanks, Andrew, for the question. So at MSI, we are a learning organization, and we are constantly looking for ways to improve intervention, ensuring that we are reaching the persons who need the services most. So the answer is yes. Just like Vika had mentioned, yes, we have the typing tool and we have the listening aid. We are currently working towards a leave behind that is more targeted based on the vulnerability that has been identified with the woman during the counseling session or the demand generation session. So yes, we will continue to work with Pathways to further develop tools to address areas of constraint.
Great, thank you so much. Sorry, someone just came off mute. I wasn't sure if you had a question. But we've got one in the chat. Kumal's asked if the learnings are different from urban and rural tools, and that was actually one of my questions. So was hoping you all could respond to that. Thank you.
GBK.
All right. So the issues that we had for translation are more in rural settings than the urban settings. But the overall learnings are from both urban and rural. The tools were tested in urban and rural settings, but some of the nuances around translations are things that we are picking up from the rural settings much more than the urban settings.
Thank you. We've got time for maybe one more question. Do we have anyone? We've got a lot of folks here. This is great to see everyone tuning in. And I just want to comment, if you haven't had time to digest, we are going to share the slides and the recording from this webinar with everyone who registered. So if you want to hear the presentation again or share it with a colleague, you'll be able to. Okay, Babita, you've got a question. asking if the pathway segmentation, oh, we've got more questions coming in. Typing tool was used in a physical form.
Yes. So they like the copy that I'm holding now, if you can see, they are printed, so they are used in physical form, not digital.
But just to also add, I think this is also in response to the question from Andrew around further innovations that we can do. This can also be turned into a digital tool, exactly so that depending on the environment and circumstance of the provider and the demand generation officer, they are able to apply it. But we see or we think that digital platform or digital tools will be more applicable for urban areas where the paper booklets will be more applicable to the rural communities. So yes, currently it's in paper form, but it can also be digitalized as a digital tool as we make progress with this.
Yeah. Thank you. We maybe Babata, I can connect you with Chibike, and you all can have a conversation, a side conversation about how you created the booklet, if that's okay. If you've got 30 seconds to answer just this one question about adolescence, you said it was really useful using these tools for adolescents. So maybe 30 seconds, and then we'll turn it over to Pratasha.
Chibike, do you want to take a go at it?
All right. So perhaps part of our target population is also adolescents, and in the north we also have adolescent population in terms of SRH mobilization that we do. So yes, we have adolescent population within as part of our target population. And maybe Yogesh, you can talk about the married or unmarried adolescent rate also.
All right, thanks, Chibike. So just in a nutshell, adolescents suffer multiple vulnerabilities. Beside the poverty and other determinants of health that they are faced with, like the adult women, the adolescents also face the social challenge around SRH services not being for adolescents, but for older population. So this too also is helping our demand generation team in the communities to first of all profile, and then following that profile, they are able to now target the conversation to what will resonate the best and the most to that client they are seeing, be it an adolescent client. And what we have seen is we are seeing increasing change towards willingness to uptake service because of that targeted conversation with adolescents. But more importantly also is from the profile and the segmentation, we are able to identify who are the influencers of these individuals. Sometimes it could be their parents, it could be the significant male in their lives, it could also be the community and the religious leaders. The team is also using that information to have targeted norm change conversation in communities that is helping to drive adolescent uptake. So it's helping to address the barriers that are limiting adolescents within their environment to take up services.
Thank you so much. I think there's probably more conversation that could be had, but we're going to turn it over to Pratasha now. And I do encourage you, if you have a few questions, continue dropping them in chat, and Ugeche and Chibike, maybe you can just respond in the chat. Pratasha, over to you. Thank you.
Okay. Thank you so much, Amanda. Hello, everyone, and it's great to see this engaging discussion with the MSI team. Hopefully, you'll connect offline as well and get to know a lot more of their learnings. I have 15 minutes today. Hopefully, I'll be able to stick to time to basically give all of you an introduction to the Pathways platform. That is the one-source stop for all the information around the Pathways segmentations that Sonder and multiple partner organizations have currently worked with. For the next 15 minutes, I would encourage that all of us put on like a very specific hat. And I was just taking a quick glance at the poll Amanda had, and we have a lot of like implementing partners or personnel from implementing agencies on board. So for the next 15 minutes, let's try to take on the role of a practitioner from an implementing agency based in Kenya. And while I know that could be like a little different to take on a specific role, it'll just help us navigate the platform and try to understand what all could Pathways help you with when you're trying to use and apply and optimize the data towards problem solving. So let me start with where I, as an implementer today, would probably think about. So I know that Pathways is a platform, and it's making sense of data in a way where we have moved away from just a very clinical understanding of health to including more things which are social. So moving on from biomedical to social is something that I understand Pathways provides me. I also understand that Pathways kind of moves away a little bit from the locus of the health center as the place where all health conversations and all health decision making needs to happen. And Pathways allows me to look at the journey of the woman before she even reaches the health center. I also know as an implementer that Pathways is basically looking at the life course of a woman. It's looking at multiple aspects of her life, not just one. So it looks at very innate internal aspects like her experiences, her childhood, her health mental models. It looks at more interactional variables like intimate partner dynamics, household relationships, community dynamics that she has. And then it looks at like broader social factors like the lived environment, the natural environment, the man-made systems that she engages with. So it tries to cover all aspects of her life. And within that, it sort of unpacks where the source of her vulnerability towards bad health outcomes are. And the fourth thing that I understand before going into this platform with the data is that Pathways basically talks about reaching women where they are, meeting them where their needs are. So it's basically not having a one size fit all solution for everybody, but tailoring or curating or finding the specific need of the woman and answering to that. So these are four basic things that I have some understanding around before I reach this platform as an implementer from Kenya. Now that I know these things, my first question would be, okay, Pathways tells me that I have looked at the population slightly differently based on vulnerability. So now, what does this population look like? Who are these segments? What are these segments like? Who is the largest? Who's the smallest? What are the sizes? Where are they? So basically an introduction into how the population itself could have been divided based on Pathways. So the platform, once you enter into the Kenya segmentation, the very first thing that you see on the screen will give you a very crisp introduction into the population level subcategorization or the segmentation exercise. So if you look at it here, you already get to know that the Kenya segmentation basically is it has 4 urban segments and 4 rural segments. So the country is broken up into 8 different segmentations, and 61.3% of the population is concentrated in rural segments. The rest, nearly about 40% in urban segments. And among that, there are some segments which are nearly 25%. So R3.1 is a 23% large segment. And there are some segments which are very, very small, like say an urban segment called Urban 4 is basically a 1% segment. But you might be, again, curious as an implementer. Okay, I've got an understanding that there are rural, there are urban, there are 4 each, there are 8 segments in total. What are these like 1, 2, 3, 4? How do I make sense of that? So if you go to this part of the platform, the very first thing you could do is you could start arranging these segments from most to least vulnerable. So you see the pattern here. You see that the 4s, or the segments which are categorized as 4s, are the most vulnerable segments, and the segments which are categorized as 1s are the least vulnerable segments. So you can see an urban and a rural 4. So there is a urban most vulnerable, there is a rural most vulnerable. Their population sizes are quite small, right? So the rural most vulnerable segment, which is the most vulnerable segment overall in the country, because this sorting shows us most to least, is just 7% of the population. The urban most vulnerable segment is maybe slightly better off than the rural segment, but it's a very small segment. It's just 1.4% of the population. Then we have two rural 3s, right, which are more vulnerable segments. It's not like as bad as the rural and the urban 4s, but it's not. I mean, it is still vulnerable. It's adequately vulnerable, and you see 3.1 and 3.2, meaning there are two distinct segments with the same level of vulnerability, but there are different reasons as to why they are vulnerable. You can see their populations as well. And as you move down, you see the least vulnerable. This is relatively the least, right? It doesn't mean to say that they are not vulnerable in any way. They have their own barriers towards optimal health outcomes, but relatively among the 8 segments, these are the least vulnerable segments, and they are roughly about 17% of the population each. You can also use the platform to very immediately sort it out in terms of sizes. So you see that the biggest segment in Kenya is this more vulnerable segment, which is rural, which is 23.4% of the population. And there are some segments, 3 segments at least, which are less than 10% of the overall population. That just means finding them will be more difficult, but 2 among them are already the most vulnerable. So they are small because they are difficult to find, but at the same time, they are the most vulnerable, which could be pulling down indicators substantially. There is a small write-up here as well, which could give you like a very quick snapshot of the segmentations and some broad learnings around this. Like, for instance, let me call this out. It's interesting to note that there are 2 segments, one each in rural and urban areas, which comprises 22% of the population, which are entirely composed of unpartnered women. So this is something we want to offer you in a snapshot, that while there are 8 segments, there are 2 segments which are already there, which through the course of your exploration you'll come to, which are composed entirely of women who are not in relationships or not partnered at the present moment. That seems like a very important point for an implementer when you're trying to think of programming along RMNCH areas. So along with sizes and distribution, you also get like some immediate call outs in terms of the composition of the segments. Now that you've been introduced to the segment as an implementer, the next question that I might have is, okay, I've got this, but I've heard that the Pathways platforms generally talk about RMNCH outcomes across a continuum. Does it have the outcomes that I want to focus on? So maybe as an implementer, what I'm looking at is, say, family planning. And it's very crucial to me to understand, is Pathways even talking about family planning? Is it talking about some other associated behaviors with family planning? Because if it's not talking about it, while the population distribution could be very meaningful, it might not be as useful for me. So you could just scroll down. And the first thing that you can see here is the range of health outcomes and behaviors that the Kenya segmentation looks at. So you could easily scroll down. You can look at the categorizations of health areas and then look at the indicators or outcome areas which are there. Or else a simpler thing would be just type in and check what indicators are of most value to you. What is it that you are focusing on? So say I want to look at family planning. So there is an indicator on no modern family planning usage, and I can already see some population, like segment level distribution, where the most vulnerable segments, say the R4 and the U4, are above 70%, like 75% of women and more don't use modern contraceptives, while there are some segments which are around the 30% mark, but generally most segments have around just 30% of 70% of modern contraceptive usage. That's like the highest usage you would see. So you're already starting to see what these outcomes are. I could also look at other variables, like say I want to look at stunting and I want to see, are there variables around stunting? You can start seeing that. I want to look at some health behaviors, like say ANC. you have a lot of behaviors that are already captured. There's no ANC visit. There is less than 4 ANC visits. Late ANC, right? No ANC visit in first trimester. These are all very important outcome areas where you can see how different segments perform along these indicators. And based on that, you can make a decision on where you want to focus. So now we've done one round of introduction on segments. We've done one round of verification of which are the outcome areas I want to look at. And the platform very clearly gives you an introduction to that. The third thing which implementers usually want some information on quite quickly is, well, there are 8 segments, but what are the segments in the area I'm working, right? I am working in Kenya, but I'm largely focusing on, say, 2 states in Kenya. And I really want to understand, do I look at all 8 segments there? Do I look at some segments? If I want to focus on the most vulnerable segment, like a R4, is it even there in the geography where I'm working in? So prevalence understanding is quite critical and a very early need for implementers. And Pathways gives you a very detailed understanding around where these segments lie. So you can go to this section, which is the prevalence map. And if you just scroll over the map, of course, you can start seeing what the segment level distributions are. But let's go a little deeper. Like say, as an implementer, I want to work in Homa Bay and I want to work in Nakuru, right? And I selected these 2 geographies. And now I get a clear sense of which are the segments that I can find in a Homa Bay. So if you look at this, you will see that in Homa Bay, predominantly the segments that you will find are rural 3.1 and rural 3.2, a little bit of like rural 1, and very few urban segments, right? Urban segments are just about 10, 14, like under 15%. The rest of it is rural. But most importantly, what you see here is the most vulnerable segment, which is a rural 4, or even the most vulnerable urban segment, is not what I'm going to find in Homa Bay. So if I'm planning to prioritize based on which segment I would look at, I have 2 ways of doing that. I could either work with the segments who are present in Homa Bay, or else if I want to work with the most vulnerable segment who has the worst family planning outcome, I might want to shift my focus to certain areas where a R4 is there, because it's certainly not there in Homa Bay in that capacity, while these 2 segments are predominantly there. Even in a Nakuru, you see that it's mostly urban segments which are present. So 32, 14, 18, so more than 50% segments are urban. Even here, the most vulnerable rural 4 segment is just 1%. It's 7% in the country, but in these 2 geographies, it's only about 1%. So you're getting like a very clear prevalence understanding, which will allow you to tailor your strategy and decide which segments do I work with more, which segments do I deep dive into, which segments do I explore more, and then strategize around, instead of again having to work with all segments. Now, say if I'm still interested as an implementer in working with the most vulnerable segments, like a rural 4 and an urban 4, even though they are 8 or 9% of the total population, I would want to know where these segments are. So if I look through, maybe these are the paths. So if you look at Marsabit or you look at Turkana, which are in the northern part of Kenya, this is where you see like a very strong concentration of the most vulnerable segments. So here, this 7% R4 at a country level is 60% of Turkana. It's 73% of Marsabit. So these are the states where the most vulnerable population largely resides. There will be other states where they are present as well, like say in Baringo, it's 16%. Even when we go like down south, there are some states, like say in the Tana River area, which is in the west of Kenya, it's about more than 50%. In some smaller states, it could be like in Narok, it's 13%. But the larger concentration is something you can map and you can strategize accordingly. Even like the urban most vulnerable segments, you can find out where they are. Like say these are the parts where you'll see urban 4 segments stand out. Like it's 14% here. In Wajir, it's 32%. In Mandera, it's 33%. So northwest is where it's where it's standing out a lot. So prevalence and using prevalence numbers based on vulnerable populations to use the data is something the platform can really help you out with as an implementer. And this is one of the tools that we often recommend. Now that you've had like some understanding of introduction to segments, prevalence numbers, outcomes, now the time comes to actually look at how do I solve? Like, I know I want to work on family planning, but even within family planning, how do I know how segments are really faring, right? This is a tool which we call the comparison tool, which is a very interesting way to look at data. So if say at this point, I have selected all segments and I want to look at a couple of factors around health outcomes, I select this add version and I go into these health areas. I could explore each of these areas, or if I already know what are the outcomes I have in mind, I could just type it here. So say I'm looking at FP, and I, along with this, simultaneously, like side by side, I want to look at some clinic-based behaviors. So maybe I want to look at ANC. So let's click like a less than 4 ANC visit, perhaps. And because it's modern family planning usage, and I have an assumption that there is some counseling that is supposed to happen in clinics after delivery, let me try to find a proxy indicator for that. Maybe I could look at PNC. So let's look at no PNC for mother. And then let me look at what more could I find? Like say, let me look at 0 dose, because vaccination is also something that we could use. So I'll go to all, and then I'll select 0 dose child.
Natasha,
Right?
sorry to interrupt. We're getting really close
Yeah.
on time.
Yes. I'll just wrap up very quickly. So now we have like these factors which you can see together. And what you see is that if I just select the rural segments, there is a clear distinction between the 0 dose prevalence between some of these segments and the family planning numbers that are kind of coming up. Which gives us an indication that probably clinic access is not the problem. Maybe there are certain other reasons as to why this is happening. And if I want to explore it further, I can look at the vulnerability factors as well. And I could look at, okay, let me try seeing what are some of the associated factors with family planning. Could I look at, say, partner? Or decision making, perhaps. Let me look at decides family planning and try to see how much decision making authority do these segments and women in these segments have around family planning. Or
Natasha,
I could look
sorry
at,
to interrupt.
say,
I think we've got 1 minute left.
yes. Yeah, I'll just wrap up. So you can look at some of these as well. Now, the last thing we could look at is a deep dive into the segments. So you can go into a rural 4 segmentation. You can look at the ages, the partner age, the religion. You can, in the first screen itself, you will find some of the key vulnerability factors that make this segment what it is. So here you have assets, education, IPV justification. So some of the key factors which stand out. You can go into the vulnerability factors as well and do a deep dive and know the segment much better. Right at the introduction part, you can also see some of this prevalence data. You can go back, and if you go to this part, this is where you can get the typing tool, and this is the typing tool. And I'll probably not go a little deeper into this, but the typing tool is accessible to everyone on the platform when you access any segmentation. And you can use this for identifying people belonging to different segments. Like MSI used an analog version, you can use a digital version as well. And this is a decision tree that immediately allows you to understand which segment belongs to which person belongs to which segment based on certain questions. I'm sorry, I ran out of time, and there's a lot more that the segmentation platform would allow you to visualize. We ran through a few things as an implementation, as an implementer. What I would encourage you is probably to try out this small task by yourself. If possible, maybe you could take a screenshot of this and try to work through this particular problem. It's a fun one. It's just deep diving into data and putting on like role playing as an implementer a little bit in a very different scenario. So we have a scenario from Matam State in Senegal, who is preparing to implement a cervical cancer screening program. And we are trying to ask you, how do you think this cervical cancer screening program might work in Matam? And there are a few questions that you could also look at, and we could, in our next session, convene, and maybe if you have some pointers, you could share that with us. I'll stop here. Amanda, over to you.
Great, thank you. Thank you so much for that fantastic deep dive into the platform. We'll share these slides with everyone. Maybe we can briefly go to the next slide, Pratasha. I had a quick comment.
Sorry. Yeah, just.
Apologies for running over everyone. We're close to the end. So I just wanted to
Yes.
share before closing that we have several updates from the community front. Pathways will be at the International Maternal Newborn Health Conference in Nairobi at the end of March. We've got 4 sessions, including a panel presentation, more about this platform at the Innovation Marketplace, and then some very engaging interactive sessions through a storytelling showcase and a participatory learning session. So if you're planning to be at this webinar, please reach out to us. You can connect with us on LinkedIn and just share you'll be there. We'll also be sharing more information about the times for these sessions. We will also have more of these community webinars this year, so look forward to sharing more implementations of Pathways through those events. And last slide, I just want to thank you all so much and encourage you to follow us on LinkedIn. View our website, and I've got this barcode. If you could quickly scan this, it's 4 quick questions to give us your feedback on today's session. We would really, really appreciate that because it helps us improve our future community webinars. So again, we will send all of this out to everyone. Thank you all so much. Fantastic session today, and thank you all thank you to our presenters especially.
Thank you very much, Amanda.
Thank you.
Thank you, Amanda. And thanks, everyone.